Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
This 16-year-old high school student is an excellent systemic and has just completed orthodontic treatment. His chief complaint is recession and tenderness of the gums around the left lower central incisor. All lower incisors are in labial version following the orthodontic therapy, and the labial tissues covering the teeth are thin. At the bottom of the gingival cleft, the sulcus extends apically to the mucolabial fold. The distance from the cemento-enamel junction to the free gingival margin at the cleft is 6 millimeters. Pull on the lip moves the free gingival margins associated with the cleft. A periodontal probe is used to outline the planned incision. The area has been anesthetized, and the mesial free gingival margin is excised with a barred Parker number 12B knife. An attempt is made to excise all of the free gingiva to the bottom of the gingival crevice. A similar incision is made for the distal side of the cleft. These incisions extend into the alveolar mucosa. Then an incision is made around the apical border of the cleft, excising the epithelial lining of the free gingiva. The excised tissues are removed with a curette, and the crevicular areas are curetted to assure removal of all epithelium. The root surface is also curetted to remove surface secretions and to eliminate some of the labial protrusion of the root. The denudation of the root in the curetted area extends 3 millimeters apically to the mucolabial fold and 9 millimeters apically to the cemento-enamel junction. The second incision is outlined with a periodontal probe starting at the distal aspect of the cleft, extending into the gingival sulcus of the lateral incisor, over to the cuspid, and down vertically to the alveolar mucosa at the mesial buccal aspect of the cuspid, and with a slight releasing incision into the alveolar mucosa. A barred Parker number 12B knife is used for release of the split flap. The incision is made on the outer surface of the periosteum about 1/2 millimeter from the bone. A reverse bevel crevicular incision is made on the labial surface of the lateral incisor and extended through the interdental papilla over to the cuspid. releasing vertical incision is made from the alveolar mucosa to the mesial aspect of the cuspid. This incision is extended 2 to 3 millimeters mesially into the alveolar mucosa. The flap is dissected loose from underlying periosteum with the barred Parker number 12B blade. The flap is gently deflected from the line of incision with a blunt instrument to facilitate dissection from the periosteum with a minimal trauma to the flap. The dissection is extended through the zone of attached gingiva into the alveolar mucosa. When the flap is reflected, the periosteum on the surface of the bone is visible. The flap is immediately placed back to its original position, and the mesial aspect of the cleft is inspected. The frenum attachment is excised with the barred Parker number 12B blade to avoid future frenum pull on the free gingiva. The flap is gently pulled laterally to cover the cleft. It adapts well to the surrounding tissues and can now be sutured in the new position. The suture needle is passed between the central incisors from the lingual to the labial side. Then the needle is passed through the mesial aspect of the flap. The flap is placed over the cleft, and the suture needle is threaded back between the central incisors to the lingual side. Subsequently, the needle is threaded from the lingual to the buccal side between the lateral and central incisors. Since these teeth did not have a tight contact, the suture slipped up from the interproximal space. The distal aspect of the flap is then engaged by the needle and the suture placed between the lateral and central incisor so it can be tied on the lingual side of the tooth. The flap is held closely to the tooth with this suspended suture. Here another suture has been placed at the mesial border of the flap to hold it securely in the desired position. There is no lip pull on the flap. The knot of the suspended suture is shown on the lingual aspect of the tooth that had the labial cleft. In the preparation for a free gingival graft, a piece of tin foil of approximated size is placed over the surgical defect. The tin foil has been cut to fit the size of the defect. tinfoil is placed on the palatal mucosa in an area of no rugae. An incision is made along the borders of the tinfoil with a barred Parker number 12B blade. This incision should extend through the mucosa and into the submucosa. The graft is cut loose with an Orban knife. The graft should be thick enough to have a proper connective tissue base, but should not extend into the palatal fat pad, since fat tissue would not provide a good base for adhesion of the graft. The thickness of such a graft should be between 1 and 1.5 millimeters. The graft should be dissected loose without any trauma and should be handled very carefully. The graft has been removed and a surgical dressing is applied over the donor site. The dressing is locked interproximally between the teeth using a plastic instrument. The free graft is placed over the periosteal defect following the laterally positioned flap procedure. It has now been sutured to the distal wall of the surgical defect with 5/0 silk sutures. Both the free graft and the lateral sliding flap have been held in position for a couple of minutes with a piece of gauze moistened in sterile saline solution. It is important to have a viable periosteum under the free graft in order to get a take of the graft. Therefore, a split flap procedure was used during the laterally positioned flap procedure. It is also assumed that there is less resorption of the thin labial bone following a split flap procedure rather than a full flap procedure. Acromycin ointment is spread over the flaps and the sutures. Tinfoil is adapted to the wound area and to the adjacent teeth. Surgical dressing is placed on the top of the tinfoil and locked in between the teeth with a plastic instrument. The surface of the dressing is trimmed with the lip to assure full freedom of lip movements. A small piece of lingual dressing has been placed to provide full coverage of the sutures and to help hold the labial dressing in place. One week post-operatively, the dressing is removed. There is some debris on the wound surface. The sutures are carefully removed. After the wound has been cleaned by sterile saline solution, a new surgical dressing is placed over the area of surgery. The donor site in the palate has healed to the extent that a new dressing is not needed. "6 weeks after the surgery, the donor site in the palate has healed completely. The aesthetic results at the site of surgery are excellent. Notice also that there is a shallow gingival crevice with the typical blanching when probing to the bottom of the crevice. The free gingival margin is approximately at the cemento-enamel junction, and the gingival sulcus is about 1 millimeter deep, both for the central and lateral incisors.
This 57-year-old woman is in good systemic health. However, she has gingival recession, which is most extensive on the labial aspect of the two mandibular central incisors. When her lip is pulled forward, there is tension created on the free gingiva in this area. This indicates the need for mucogingival surgery. A split flap and free gingival graft will be used to correct this defect. A piece of tin foil is pre-cut to the anticipated size of the free gingival graft. After local anesthesia has been administered, the labial surfaces of the involved teeth are thoroughly curetted. The curettage extends to the bottom of the gingival crevices. The exposed surface layer of cementum and the epithelial lining of the gingival crevices are completely removed. Curettement also includes the apical areas of the labial clefts. The incision is outlined with a periodontal probe. The entire free gingiva bordering the areas of recession will be excised and the mucobuccal fold deepened by a split flap procedure. A Bard Parker 12B blade is used for the initial incision. Notice how the blade is slanted to provide a wide zone of connective tissue for the graft. The mucobuccal fold is deepened with a split flap dissection on the outer surface of the periosteum. The incision at the distal side of the gingival defect is also slanted to provide a wide bed for the free gingival graft. An incision is also made at the bottom of the gingival sulci and through the interdental papillae. The free gingiva is then dissected loose with the Bard Parker 12B knife. The periosteal bed should be left undisturbed on the surface of the bone. The excised free gingiva is removed with a curette and all tissue tags eliminated. The mucobuccal fold is deepened about 1/2 millimeter over the surface of the bone. This creates a split flap with the periosteum remaining on the bone. The lateral margins of the graft bed are also prepared. The tinfoil pattern is checked against the bed to make sure the graft will be adequate in size and correctly shaped. It is then placed in the palate on an area without rugae. An incision is made through the palatal mucosa into the submucosa and extended along the periphery of the tinfoil. The graft is dissected free with Orban knives at a depth of about 1.5 millimeters. It should not include any of the palatal fat pad, since this tissue is not suitable for grafting. The dissection must be carefully performed so as not to traumatize the tissue. The corner of the graft is gently held with forceps while it is freed from the underlying tissue. Surgical dressing is then applied over the donor site. It is locked into the interproximal spaces with a plastic instrument. The suturing of the graft is illustrated in schematic drawings. A suture is threaded from the lingual to the buccal side between the lateral and central incisors. It is inserted through the corner of the graft and carried back through the same space to the lingual side. From here, it is returned to the labial aspect between the two central incisors. It is inserted through the graft and carried back through the same space to the lingual. This procedure is repeated between the adjacent central and lateral incisors. The next drawing shows the total suspension suture and how the graft is pulled in interproximally when the suture is tied. The graft is held loosely in place before tying the knot. The lip flap is sometimes sutured to the periosteum at the bottom of the mucobuccal fold extension, but was not done in this case. Suspension sutures can be seen from the lingual aspect. The ends are then gently drawn taut and tied. Lateral borders of the graft are sutured to the margins of the wound. 5/0 silk sutures are used in an atraumatic needle. The graft is held in place by gauze, which has been moistened with sterile saline. Moderate pressure should be applied for a couple of minutes. The pressure removes blood from under the graft and prevents further hemorrhage. – 2.5% acromycin is placed over the area of surgery and sutures. Tinfoil is used to cover the area of surgery. A surgical dressing is placed over the tinfoil. The dressing is molded with the lip and tested for occlusal interference. The dressing is removed 1 week following the surgery. Part of the surface of the free graft covering the labial aspect of the teeth is sloughing off. A new dressing is placed. The palatal donor site has healed completely 5 weeks after the surgery. The gingival crevice in the graft area is shallow. There is a slight gain in gingival attachment at the labial surfaces of the central incisor and sufficient attached gingiva to avoid muscle pull around the mandibular central incisors, which was the main purpose of the surgery. The graft has matured, and there is no muscle pull on the free gingiva of the central incisors. The new attached gingiva has maintained a sufficient width. There still is some discrepancy in the depth of the vestibular fornix associated with the surgical dissection in the operated area. The free gingival margins are located 5 millimeters apically to the cemento-enamel junctions, indicating a gain of 1 millimeter compared with preoperative measurements. The crevice depth is 1 millimeter compared to the preoperative depth of 2 to 3 millimeters. There is good gingival adaptation.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.